Hi everyone, my name is Sarah, and today I will be talking about how to manage insulin-dependent diabetics in the perioperative setting. The reason I thought this would be a good video is that diabetes is common, and it is inevitable that we as junior doctors will be asked to provide plans for diabetics who are fasting for surgery. Although there is no consensus as such about the optimal way in which to manage diabetics in the perioperative setting, there are some general principles which can be used. When in doubt, it's always good to refer to the hospital guidelines or to speak to the endocrinology registrar at your local hospital who can give you some advice. There are some areas that this video will not cover, and these are blood sugar level optimization prior to elective procedures, patients who are undergoing bowel preparation, and diabetics who are on diet-only or oral hypoglycemics-only regimes. As an overview, this talk will be going through insulin-dependent diabetics and their management in the immediate perioperative setting. This will be in the context of both morning and afternoon lists, as well as major and minor procedures within that. So let's start by going through some definitions. Firstly, insulin-dependent diabetics. These are people who require insulin to manage their diabetes, not just oral hypoglycemics. Therefore, this definition includes not just type 1 diabetics, but also people with type 2 diabetes who may be insulin requiring. For people with type 1 diabetes, they must have insulin on board because if they don't, they run the risk of becoming ketotic. Therefore, we must never completely withhold insulin in type 1 diabetics. People with type 2 diabetes who have been on insulin for a long time sometimes behave like type 1 diabetes. Although insulin is not essential in these people, we have to be careful and manage them similarly to type 1 diabetes. Major surgery is usually one that requires an overnight admission. Minor surgery covers procedures that don't require overnight admission or are considered day procedures. And this definition can vary according to hospitals. For the purposes of our talk, we will consider minor surgeries as those that last only a couple of hours, for instance ending by 10 a.m. if it is a morning surgery. The first thing to understand is that there are different types of insulins. These are usually grouped by their duration of action. I like to keep it simple and remember only 4 main groups of insulins, the first being long-acting insulins. These include insulins such as Lantus, Oglargine, and Levemir, which is Detamir. The next main group is intermediate-acting insulins, such as Isophane and Protamine, which you may recognize as Profane or Humulin NPH. The short-acting insulins include regular insulin, such as Humulin R, as well as the rapid-acting insulins such as Humalog, which is Lispro, Novorapid, which is Aspart, and Apidra, which is Glulicine. The final group is premixed insulins such as Novamix 30, Humalog Mix 25, and Mixtard. These usually contain a combination of short-acting and intermediate-acting insulin. For example, Novamix contains Aspart and Protamine. There are 3 commonly used insulin regimes, the first being basal bolus therapy. This is where a background or basal level of insulin is provided in the form of a long-acting insulin. Extra doses of short-acting or boluses are then provided with meals usually. Another common insulin regime is one that uses premixed insulins. Premixed insulins can be given up to twice or 3 times a day. The last commonly seen regime is type 2 diabetics who usually take oral hypoglycemic agents as well as insulin. While we will not be talking about oral hypoglycemics today, it is important to be aware that this does occur. Now let's move on to discussing how to manage insulin-dependent diabetics who have morning procedures. This will cover 3 main management scenarios. The first is patients undergoing major surgery. Secondly, patients undergoing minor surgery. And thirdly, what to do with patients undergoing minor surgery who face unexpected delays in their surgery times. To start with, it is important to mention that in an ideal scenario, diabetics should be placed first on any morning list, as this causes the least disruption to their blood sugars. For insulin-dependent diabetics undergoing major surgery on a morning list, these patients should be fasted from midnight, as with any morning procedure. Let's look at what this means for the insulin regime. Generally, the day before surgery, no change is required to the insulin doses. Since the patient will be fasting from midnight and will not be having breakfast, it makes sense that on the morning of the surgery, that we withhold any short-acting insulin which may be due with their usual breakfast. Depending on hospital protocol, in the intraoperative setting, an insulin glucose infusion is usually commenced at the induction of anesthesia. This insulin glucose infusion is then continued into the post-operative setting until the patient is able to eat normally again. Here is an example. Jerry is a 60-year-old gentleman who is a type 1 diabetic who will be undergoing a femoral popliteal bypass scheduled for 8 a.m. He's normally on 12 units of NovoRapid 3 times a day with meals and 24 units of Lantus at night. You are reviewing him on the ward the day before his surgery. What would your plan be for managing Jerry's insulins in preparation for his surgery and fasting? If we go back to the algorithm which we looked at before to answer this question, we can refer to the first 2 sections over here. We can see that in this case, the day before surgery, that we do not need to make any changes to Jerry's insulins. Therefore, he should be able to have his normal nightly dose of Lantus, as well as his dinner time dose of NovoRapid. The morning of his surgery, however, we need to withhold his morning dose of NovoRapid, since he will not be eating breakfast. It is important to note 2 things here. Firstly, that Jerry is a type 1 diabetic, and therefore is insulin dependent. The second thing to be aware of is that we should never completely withhold insulin in a person with type 1 diabetes, as they run the risk of developing diabetic ketoacidosis. In Jerry's case, however, although we have withheld his morning short-acting dose of insulin that he would normally have had with his breakfast, he would still have insulin acting in his system, as he would have had taken his long-acting dose of Lantus the night before. It is still important, however, that we monitor his blood sugars at least 2 hourly in the perioperative period to make sure that Jerry is not becoming hypo or hyperglycemic. Alright, let's move on to managing patients on a morning list for a minor procedure. In this first scenario, we're going to assume that the procedure will go as planned. As with any morning procedure, the patient will be required to fast from midnight. Also, for the purposes of our case, we're going to assume that any minor procedure scheduled for first thing in the morning will finish by 10 a.m. The algorithm for this is similar to the one for major procedures, where the day before, it is often safe for the patients to have the usual doses of insulin. Similarly, because the patient will be fasting from midnight, any short-acting insulin which is due with breakfast is usually withheld. The difference in this algorithm lies in the intraoperative and post-operative management of the patient. Depending on hospital protocol as well as on the stability of the patient's blood sugars in the intraoperative period, the patient's blood sugars can either be monitored closely or an insulin glucose infusion commenced if the patient has erratic blood sugars, or if the procedure is anticipated to become prolonged or complicated. If everything goes to plan and the procedure is completed by 10 a.m., the patient can be given a delayed breakfast and be given their usual breakfast dose of short-acting insulin as well to go with this. Let's look at another example which illustrates this. Brenda is a 55-year-old type 1 diabetic who is planned for a wide local excision and superficial skin graft of a skin lesion as the first patient on the morning list. She normally takes 10 units of NovaRapid with her meals and 20 units of Lantus at night before bed. You are reviewing her in the pre-admissions clinic, and Brenda tells you that, on average, her blood sugars when she wakes up in the morning are about 4.5. How will you document the management plan for Brenda's insulin in the notes? In this second scenario, there are two things that I want to emphasize. The first is what to do if a patient tends towards low fasting blood sugars in the morning, and the second is how to manage someone on a morning minor procedure list. If you were listening before, you will notice that I said that there is usually no change required to a patient's insulin the day before their procedure. In Brenda's case, however, her blood sugars are averaging on the low side, 4.5 in this case. Therefore, our main aim here would be to prevent hypoglycemia on the morning of her procedure. One strategy that we can use to reduce this risk of hypoglycemia is to reduce the long-acting dose of insulin the night before by roughly 10%. For example, what this means for Brenda is that since she usually takes 20 units of Lantus at night, reducing this by 10% would mean that we need to reduce this by 2 units. Therefore, you would consider recommending that Brenda take 18 units of Lantus the night before her procedure. If you're unsure in any way, it may be a good idea to speak to your local endocrinology registrar for advice. As we have previously discussed, on the day of the procedure, Brenda would have to omit her short-acting insulin. We will need to monitor Brenda's blood sugars closely from the time she arrives at the hospital, and assuming that everything goes to plan and her procedure is completed by 10 a.m., Brenda can be given a delayed breakfast at that time and be given the dose of short-acting insulin which she had missed early in the morning, which is 10 units of NovaRapid. Now it's time to look at the scenario of a morning minor procedure list, where the procedure is delayed or the blood sugar is elevated prior to the procedure. In this algorithm, the main parts that are different are what you would do on the morning of the procedure, as well as what you would do in the post-operative period. The situations in which you may need to apply this algorithm would be if the patient is fasted and has had their usual insulin withheld in the morning. In these cases, if the procedure is delayed unexpectedly, and or if you find that the patient's blood sugars are trending up, you may want to consider a modified insulin dose. Depending on what the patient's normal insulin regime is, it is possible to modify this in order to give the patient some insulin to help control their blood sugars. This can get a bit tricky, given there are different combinations and types of insulin regimes. So if in doubt, consider speaking to the endocrinology team or refer to the guidelines at your local hospital. Generally speaking, as a rule of thumb, we could give 50% or half of what they would normally have in the morning if they were not fasting. For example, if a patient normally received 40 units of long-acting insulin in the mornings, let's say Lantus, you may consider giving them 20 units instead if you notice that they're becoming hyperglycemic. Alternatively, if the patient's blood sugars are becoming erratic, you may want to consider an insulin glucose infusion instead. In the post-operative period, patients are normally able to have a meal, for example lunch, if the procedure has been delayed. Since they already have insulin in their system from what you would have given them earlier in the day, it is possible, for example, to give them half of what their normal short-acting insulin would be if they were to have a meal. Let's look at an example that demonstrates this concept. Ben is a 68-year-old gentleman with type 2 diabetes who was meant to have a hernia repair at 8 a.m. today. Unfortunately, his procedure has been delayed until about 9:30 in the morning. Ben is normally on a regime of pre-mixed insulin and has not had his morning dose since he has been fasting. He usually takes Mixtard twice a day, 40 units in the morning and 20 units in the evening. His blood sugars since his arrival have been gradually trending up, and they are currently about 9.5. What plan will you give the nurses for managing Ben's blood sugars? Okay, so in this scenario, it's a little bit different because Ben is on premixed insulin. However, the same rule of thumb applies, where we can halve what they would normally have by 50%. In this context, where Ben's procedure has been delayed and his blood sugar is becoming increasingly elevated, it is possible to give Ben half or 50% of what he would normally have in the morning. Therefore, if Ben usually takes 40 units of Mixtard in the morning, then we could consider giving him 20 units. And we'd have to monitor his blood sugars quite closely after this. In the post-operative setting, Ben doesn't usually take short-acting insulin because he is on a premixed schedule. However, depending on what his blood sugar is, you may want to consider giving him a small dose of short-acting insulin to go with his meals post-operatively. In summary, for insulin-dependent diabetics who are undergoing morning procedures, generally, no change is required to their insulin regime the day before the procedure. The morning dose of insulin is then withheld as the patient will be fasting. Depending on physician preference, an insulin glucose may be considered for intraoperative blood sugar management. For patients who have undergone a major procedure, this usually is continued until the patient is able to eat and drink normally. Patients undergoing a minor procedure, however, can usually be given a late breakfast with their previously withheld dose of short-acting morning insulin. For patients whose procedures have been delayed or who have elevated blood sugars prior to the procedure, a modified dose of insulin or an insulin glucose infusion may be considered based on the guidance from registrars or the endocrinology team. Similarly, an insulin glucose infusion can be considered for intraoperative blood sugar control if required. Finally, in the case of minor procedures, the patient can still be given a meal with a dose of short-acting insulin once they're finished. That concludes the section on morning procedure lists. Let us now move on to looking at afternoon operating lists. Generally, afternoon procedures are less favored for insulin-dependent diabetics, as it is considered more disruptive to their glycemic control. Overall, the algorithm for management of insulin-dependent diabetics scheduled for afternoon lists is similar, whether it's a major or minor procedure. For these patients, it's possible for them to have a light breakfast at about 6 a.m. on the day of their procedure. Because they would be eating less at this meal than they normally would, it is possible to use half of what their usual dose of scheduled insulin would be. Depending what specific regime the patient is on, however, for example, in the timing of their intermediate or long-acting insulins in conjunction with mealtime boluses, the type of insulin given can differ. Therefore, if there is uncertainty, you should refer to your local hospital guidelines or endocrinology team. Regardless, close monitoring of blood sugar levels will be required while the patient is awaiting their procedure. Intraoperatively, the principle is similar to morning procedures. Therefore, major afternoon surgeries normally would require the patient to be started on an insulin glucose infusion, and minor afternoon procedures can be monitored intraoperatively or sometimes started on an infusion if they have erratic blood sugars preoperatively. Postoperatively, again, the same principles are used, where if a patient is on an insulin glucose infusion, they need to be continued on this until they are eating and drinking normally. Similarly, if they have a minor procedure, they may be able to have their usual dose of insulin with their next meal. Let's look at an example of Jen, who's a 35-year-old lady with type 1 diabetes. She has been scheduled for a total thyroidectomy at 1 p.m. Normally, she takes 16 units of Novorapid 3 times a day with meals, and 24 units of Lantus in the morning. How will you manage Jen's insulin on the day of surgery? In Jen's case, we know that based on the algorithm, she would have had her usual doses of insulin the day before. In addition, we know that she'll be able to have a light breakfast. In this situation where Jen would normally take short-acting insulin and long-acting insulin at breakfast time, the suggested approach would be to give her half of each insulin. The reason is we will need to provide her with some shorter-acting insulin to help her with her breakfast, as well as to provide her with some level of longer-acting blood sugar control. This is especially so because Jen is a type 1 diabetic and she should never have insulin completely withheld. Therefore, it is possible to give Jen about 8 units of Novorapid and 12 units of Lantus with her breakfast, followed by close monitoring of her blood sugar levels, at least 2 hourly. As a total thyroidectomy would be considered a major procedure requiring inpatient stay post-operatively, Jen would also most likely be commenced on an insulin glucose infusion. This would need to be continued until she is able to eat and drink normally. Finally, to conclude this video, I would like to recap some of the key principles covered in this video. The first is that morning procedures are preferred for insulin-dependent diabetics, as this causes the least disruption to their glycemic control. Secondly, no changes required to insulin regimes the day prior to surgery. The only exception would be if the patient has a known tendency for low blood sugars on waking. In this case, it is possible to reduce the long-acting insulin the night before by about 10% to try and counteract this. For patients with delayed procedures or deranged blood sugar levels, either a modified dose or an insulin glucose infusion may be used to help manage blood sugars. Post-operatively, insulin glucose infusions should be weaned only once patients are able to eat and drink properly. Insulin should never be completely withheld in patients with type 1 diabetes. And finally, if there is any doubt as to how you can manage your patient, please refer to your local hospital guidelines or endocrinology team. Thank you for taking the time to watch this video. I hope you found it useful and that you will feel more confident in managing perioperative patients with insulin-dependent diabetes. Until next time.